know from the medical oncology guys' side, you don't see a lot of the non-muscle invasive bladder cancer patients. Clearly, we know that BCG, which is an immune modulator, has some toxicity. There are some patients that don't do well with BCG. It can cause a lot of irritative symptoms. And then you have this subset of patients that won't respond to BCG or are refractory. Oftentimes we give them a second induction round. There is another agent for BCG refractory CIS, which is Valstar. What about some of the newer agents, and what about the use of systemic chemotherapy for CIS, or in this particular case, T1 disease?
So I think it's important to understand that when you get muscle invasion, you get an alteration in the biology of the disease, and chemotherapy then based on that becomes very useful, intravenous chemotherapy. I'm not talking intravesical. And so whilst there have been some protocols that have used transurethral resection of bladder tumours with chemo, the reproducibility of those has been questionable. And the patients that have benefited, paradoxically, have probably had muscle invasive disease that we haven't been able to detect. So chemotherapy for these patients is not part of the standard. We do have some things in the works immunotherapeutically to look at this. So there is a series of data that suggests that patients that have had tuberculin vaccine do better with BCG therapy in their bladder. And in Europe, tuberculin vaccine was continued much longer than in the United States. And so most of the data comes from Europe, but we have a SWOG study that will be led by Rob Svatek that will start soon, which sensitizes patients potentially with an injection of tuberculin vaccine before they start their BCG. And so that will test whether in fact we can get more mileage out of that first BCG therapy. And we also have integrated into a refractory setting the use of the drug that Dan has worked on extensively through the phase 1 and phase 2 studies, atezolizumab, a PD-L1 blocker, which will be given intravenously to patients who are refractory to BCG in a study led by Petrylak and Parminder Singh that'll run in SWOG, and that's SWOG 1605. So I know urologists are looking out for urology trials from SWOG. We've got a couple that are coming that are going to work on build on the work of Don Lamb all those years ago with BCG and move that forward. Dan, have you got anything to add there in terms of the early disease?
Well, I think that the overall expression of PD-L1 after BCG is still a little controversial. There have been some studies that have shown upregulation. We've actually looked back at our data set at Yale and found that the expression of PD-L1 goes along with the number of TURBTs that a patient actually has. So we're not necessarily seeing a correlation with BCG or not. But nonetheless, it's an immune target. It needs to be evaluated. You know, there actually is old data looking at an old drug called propyramine, which is an oral interferon inducer, which unfortunately had some cardiovascular side effects, which had led to the cessation of its development, but had activity in refractory CIS. So I certainly think that this is something that merits study. It may actually hopefully spare patients from cystectomies. And I'm very excited about its future.
So Dan, in the study that you're leading, you're giving a anti-PD-L1 systemically, intravenously. What's the comparator arm in that?
So
well, actually, this is being led in SWOG, but by the urologist. So it's the comparator is observation, if I remember correctly.
Yeah, I think we have a phase 2 run-in on that to look at what we think whether we think it's different from historical rates, and then there'll be some comparison.
Okay. Those are, one of the things that we know, and we glossed over this a little bit, but it takes sometimes more than a single dose of immunotherapy. 6 is the induction, then usually 3 as part of the maintenance, or 2 inductions, but usually after 2 courses or a 6+3, and it's been 6 months, enough time for the immunotherapy to work, that's when we start to declare patients as BCG refractory. There are other patients that are sort of relapsers after that response at 6 months, and those collectively can be referred to as BCG unresponsive. And I believe that's the group that's the hardest for us to treat. We have some agents, as you mentioned, valrubicin, some chemotherapies. Some of those have up to a 20% response rate, maybe a little bit higher, but it doesn't seem to be very durable even with maintenance. And so really the excitement around this new immune-based therapy is ever present. And I believe that most of the discussions that I'm aware of from FDA approval don't need a comparator because there is no standard. Cystectomy is the standard. So if they have about a 20 to 30% response rate and you can get them 6 to 12 months down the road, you've moved the needle, and that would have probably set the stage for approval.
Mike, where do we stand? Because obviously in years past we also used interferon. And obviously there were a lot of people using BCG in combination with interferon, cutting the dose of BCG. What's the data on BCG and interferon combined?
So people have talked about the dose reductions of BCG, which are necessary in some patients due to intolerance, but once you go below about a third dose of BCG, you don't get the response. And for those highest risk patients, like the one we described, T1 CIS, usually they need a full dose and they need long duration, hopefully a 2 or 3 year duration. In terms of those patients who can't tolerate or fail, there have been studies. There was a large intergroup study that looked at adding 50 million units of interferon. Interferon alone doesn't seem to work. It needs to be combined. The problem is there's a lot of heterogeneity, and those trials were developed at a time when we didn't have good definitions for BCG failure. And so when you go back and you look at them, there were many patients who maybe just had a 6-week course or maybe had a lower grade, lower stage disease, and they had good response. So there is activity there, but when you really look at failed 2 cycles, recurrence within 6 months, you don't get the bang for your buck that you wish you could get. So it's an alternative, and in some patients they do respond, but I don't think it's enough for us to say that's the standard of care.